Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us. It's hard to believe, but we are celebrating 10th anniversary of the Health Matters radio program. We are planning some special shows to celebrate the milestones, so we hope you'll stay tuned. Let's begin today by thanking our sponsors, Cleveland Clinic Mercy Hospital, Studio Hearts and Glass, and of course our socially distant technical producer, JD DeAngelis. Joining me is Brad White, a compounding pharmacist, and our very special guest, Dr. Timothy McKnight, a family physician with Trinity Health System, Twin City Medical Center. Good morning, Dr. McKnight, and welcome to the show.
Morning. Thank you, Paul.
If you've heard Oprah, Suzanne Summers, or Dr. Oz talk about bioidentical hormones and wondered what they're all about, today's show will help you understand how they can benefit both men and women. Bioidentical hormones are defined as man-made hormones that are very similar to the hormones produced by the human body. They're used for treatment for men and women whose hormones are low or out of balance. Some prescription forms of bioidentical hormones are pre-made by a drug company. Other forms are custom made by a pharmacist based on a doctor's order. This is called compounding. The U.S. Food and Drug Administration has approved a number of bioidentical estradiol and progesterone medications, which are molecularly identical to the structure of hormones generated by the human body. They've been through rigorous testing for safety and purity to be sure that each of these doses has the same amount of hormones. This morning, we're going to talk with Dr. McKnight about bioidentical hormones. We'd like to remind our listeners that today's program is also available on our podcast. Look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe.
So, Dr. McKnight, again, welcome to the show. We'd like to thank you for your service as a physician, especially during this pandemic. Please tell your listeners about yourself and where you practice.
Well, Paul, I'm 61 years old today. I'm actually birthday.
Happy birthday.
Happy birthday.
And I feel great. I feel like I'm in the best shape of my life, and I attribute that a lot to the bioidentical hormones. But I actually began my career thinking I was going to be a nutrition scientist. So I have a bachelor's in nutrition, and then I completed my PhD coursework in nutrition and a good bit of the research before I sort of ran out of time with the research and started medical school at Ohio State. So I went through my medical training and learned that the way you treat and manage disease is you cut bad things out and you use pharmaceuticals to control symptoms, or we were taught that's how you treat disease. And soon into my practice, I started to realize that if we applied nutrition knowledge, and we got people exercising and changing their thoughts, emotions, behaviors, relationships, that they could heal. So I began a wellness program kind of on my own on the side in 2003. And it was just something I did for the community, but it was hard to do this without support. So in 2006, we had a grant writer here at our hospital who submitted a grant to the Office of Health and Human Services Rural Outreach Policy. And we were awarded a $375,000 grant for 3 years. Well, that's evolved into 4 consecutive grants totaling over $1.5 million in funding for me to educate people on everything I learned in graduate school about nutrition. But since then, I've accumulated a lot more information on hormones, exercise science, behavior modification, changing emotions, the quantum physics, all those things. And it's really come down to this beautiful interwoven message about empowering people with information so they understand how they can help their bodies heal. And as I've applied this, like I said, I'm doing things at my age that I never expected to do. So I'm really excited about where we are right now, the way that we can educate people, empower them to really understand how to improve their health.
So, Doctor, what are bioidentical hormones?
Well, I think the key there is bioidentical. Bioidentical means these hormones, whether you put them on your skin, or you absorb them with a shot, or you swallow a pill where a pill dissolves in your mouth, they're bioidentical. The body can't distinguish between the molecular structure of what the ovaries and testicles make and what is entering the body. And that's the key. If it's bioidentical, it is safe if it's in the right concentrations. It's effective if it's at the appropriate levels. The synthetic hormones they're not the same molecular structure. They're close. And so the receptors in the body says, I think I know what this is. I know what we're supposed to do with this. But sometimes those messages and the interpretation of those messages get mixed up by the body, and they can cause side effects. Some of them can cause really bad side effects. Some of them can put us at risk for cancer and stroke and clots and heart disease. But bioidentical is completely identical. It's not synthetic, and that by that definition, and it's safe for us if we use it correctly.
So why haven't we heard more about bioidentical hormones? Excuse me.
Well, you guys probably know the answer to that. The drug companies, pharmaceutical industries, they develop new molecules, and anytime you develop or invent something, you can get a patent on it. And those patents usually last for 20 years. It cost $1 billion, hard to believe, $1 billion to get a drug to market. And at least 10 years of research and development on animal studies and human trials before it gets FDA approval. With that type of investment, the marketing strategies have to be really robust to convince medical providers and the community that they should use these products. So there's a lot of advertising, a lot of marketing. Bioidentical, you can't take something that's in nature and get a patent on it. So the financial kickback for something like that isn't great. So the marketing strategies really aren't there. And that's as far as I understand, that's the primary reason why most people aren't aware of this. It's just not marketed like everything else in the pharmaceutical industry.
So part of that has to be too that the average physician's knowledge is not, I guess, not there. I mean, they're so buried in all the types of stuff
Right.
that it's very difficult for them to find time to really involve themselves in this, I guess. I mean, to be part of it, I guess.
Absolutely. And unfortunately, in medicine, the first year of medical school is learning the healthy body. The second year is the pathophysiology, the disease states with the treatments for those, which is not nutrition therapy, it's pharmaceuticals. And most drug companies most medical schools have some type of a drug tie with pharmaceutical companies indirectly. And so they're funded and they need to maintain that relationship with the pharmaceutical industry. So those messages have to come through pretty strong in the medical education process that pharmaceuticals are the way we manage disease. And once you get out of medical school, the third and fourth year of medical school is really just about following around, mentoring physicians in hospitals and in outpatient offices and learning what they do and how they approach disease and trying to mimic and do what they've done. And I'm not downgrading physicians. There's great physicians. I'm inspired and motivated by very intellectual, caring, compassionate people. But the nutrition understanding, the nutrition application is not something we learn in medical school. It's something that I learned in graduate school. I forgot it or didn't think about it in medical school, but then in practice, I came back and said, no, wait a minute, this doesn't make sense. You have acid reflux. Why do you have it? Let's get to the root cause. Let's help you change your diet so your stomach and your esophagus and everything else works properly. And then people start to heal. And it's not always pharmaceutical as the first line treatment.
So I guess a lot of doctors just feel too that they're not safe.
Absolutely. Absolutely. The reason for that is the WHO trial that was a 7 or 8 year study, and they took menopausal women and they gave them 3 different synthetic hormones: Premarin, Provera, which is the synthetic progesterone, and Prem-Pro, which is the combination synthetic estrogen and progesterone. And they wanted to see if this group of menopausal women, how they would feel on these different synthetic hormones. Would they be able to control their menopausal symptoms? Well, 5 years into the study, they had to stop the study because the rate of breast cancer, heart disease, stroke, and clots was unacceptably high. They were putting women at risk for bad outcomes with these synthetic hormones. And so I was in practice at that time, and that was reported on news everywhere. Patients are calling my office. I'm taking Prempro. I'm taking, Premarin. What should I do? And I said, I don't know. I've heard the same things on the news. You probably ought to stop it. It sounds bad. And so we all just assumed that hormones were bad. And it wasn't until many years later that we understood that it's Prempro that doubles your risk, or I should say doubles the risk, but it increases your risk significantly for these cancers and vascular diseases. So we just made the assumption that all hormones are bad. And my contention is, if testosterone causes prostate cancer, then God should have made men so that right after their reproductive years, they stop making testosterone so they don't die of prostate cancer. If estrogen causes breast cancer, then as soon as women are done ovulating and having children, they should have a hysterectomy and they should have no estrogen. And we actually know that doing both of those things, because we do this to men and women when they have prostate cancer or they have, a reason for a hysterectomy, when we wipe out those hormones, we put them at great risk for heart disease, dementia, and other obesity, diabetes, other problems down the road. So it just doesn't make sense that we're negative against these hormones that provide really important protective functions to our health and well-being.
Why are so many people suffering from low or imbalanced hormones?
Well, that is the question that when I got my training, I wanted to know the same thing, because when I was trained in bioidentical hormone therapy, I thought, well, isn't menopause a natural process? Aren't women supposed to have hot flashes? Aren't men supposed to feel older when they turn 61 or in their 70s? Isn't that a natural process? And the reality is we are exposed to so many chemicals. 8,000 new chemicals since the 1900 is the estimate. The estimate is that women every day are exposed to at least 10 xenoestrogens. They're estrogen-like compounds that block signals to the cells that interrupt normal physiology and chemistry. It's believed that women are exposed to 144 foreign chemicals, foreign molecules every day. And these are the reasons why women suffer from PMS, heavy bleeding that leads to fibroid tumors and hysterectomies. This is why I see men in my office, sometimes in their 30s and 40s, with low testosterone levels that nobody has checked, because you can't have that, you're too young. So it's the environment that we're in. And it goes back to this term called epigenetics. Louis Pasteur on his deathbed recanted the idea that it's all about the DNA. He said that it was about the environment. You put the DNA in the wrong environment and you'll get sick. And it's the same thing with us. If we put ourselves in the wrong environment, it disrupts natural physiology, biochemistry, and we pay the prices with a lot of these chronic diseases. But it goes unnoticed because most of us aren't aware of this. We're not looking for it. And of course, as you mentioned, we're afraid to use it because we think they cause cancer. So we stay away from it. But Paul, that's the primary reason. It's all these new environmental exposures that we have, and we're all exposed to it every day. There's virtually no way we can avoid most of these exposures. We can be intelligent and avoid some of them, but plastics and creams that we put on our skin and fragrances that we use and foods that are laden with pesticides and herbicides, glyphosate and atrazine and all these other chemicals, they're very strong endocrine disruptors. And that's the primary reason why we have so many problems now.
Well, it's interesting that over the years, they've treated prostate cancer with, way back in my early days, they were using diethylstilbestrol. Okay.
Right.
And of course, now it's not approved for humans. It's only approved for animals. And so I don't know, where are we going with all this stuff for prostate cancer?
I tell my prostate cancer survivors that before anybody does this to you, that they take away your identity as a man by knocking out your testosterone to 0 levels. They should never do that to anybody until they've done it to themselves first. because you take away a man's testosterone, the risk of suicide goes up because they're so hopeless, so fatigued. They have urinary problems, they have balance problems. Of course, they lose their muscle mass, they gain belly weight without testosterone, they lose their libido, and they're not the same person anymore. And testosterone does not cause prostate cancer. If it did, we'd have 20 and 25-year-olds with prostate cancer when they have the highest levels. So it's terrible what we do, and it's all with the intention of we're following what science says, but science is wrong. These men feel terrible. I have a man who was a Vietnam veteran, Agent Orange exposure, at 78, got prostate cancer, had surgery, then chemically made into a eunuch. So not a man, not a woman, no testosterone, feeling awful. I said, you know what? It's been a year now. Your PSA is 0. It's time for you to take testosterone. Within 2 or 3 weeks, this guy is spending an hour and a half in the gym every day lifting weights, and he's flexing his muscles in pictures. He's doing things again. His bladder problems have resolved because we know testosterone converts to estrogen, which helps urinary symptoms. So it's just it's a shame that we don't know this and understand this better.
Very interesting.
What are some of the benefits of bioidentical hormones for women in menopause?
Also, if for your women listeners who are in menopause, you know all the symptoms that go with menopause. You know, there's hot flashes, there's night sweats, there's bladder problems, the urgency to go to the bathroom, or maybe you leak when you cough or sneeze, the lack of libido. But the other issues that are crucial for me as a provider is the risk of osteoporosis, the risk of heart disease, the risk of breast cancer goes up when you become menopausal. So I tell my patients, if we optimize your estrogen at the level that your body needs, your osteoporosis will reverse itself. I have 85-year-olds on estrogen as a treatment for osteoporosis. We see those T scores improve over time. It will help your vascular flow. So something I don't know how I missed this, but hormones can help. We know the hormones can help a man's libido and help a man, his arousal, but it can also help women. If women get more vascular flow to their clitoris, they have better arousal and better response to intercourse. It helps with the vaginal secretion and moist. It helps the urinary symptoms. In fact, it reverses these urinary symptoms, except for women who have had anatomical changes in their pelvic floor from many prolonged deliveries where their anatomy drops, and that's a surgical correction. But if it's just, if they've never had children or never had big children and they're leaking when they cough or sneeze, that's an estrogen fix. It works every time. So it helps with the eyes and the teeth and the skin, the hair, it reduces the risk of heart disease. It improves the lipid profile. So it just goes on and on. You think of what a healthy 25-year-old woman is like with adequate estrogen, and that's what a 60, 70-year-old woman should be like. There's no reason why they can't have those same outcomes.
Well, you kind of touch on the point that maybe the reason we age is because our hormone levels drop. There's a lot of theories that I've read about that with respect to, we know that men, as they age, their testosterones drop, their DHEAs drop. And I know we're going to talk about DHEA later. So I don't want to jump ahead too far. But so you mentioned optimal hormone levels in a 25-year-old man and woman, and a 60-year-old man or woman has a different level. How do you go about calculating a dose so you don't overshoot what's necessary?
Well, that's a great question. And here's an important point. In medicine, we measure everything pretty much we measure in the urine and the blood. We get ranges of what's considered normal. I'm finding that a normal folic acid level is not normal. If it's low normal, you probably need to supplement it. And it's the same with the hormones. We set these standards for where our goal is for a menopausal woman or for a man on testosterone based on the ranges, the optimal ranges. You never want to be on the low end of a range. You want to be on the high end of the range. You want to have ranges, blood levels, where you would have had them in your peak, in your prime, say in your 20s or early 30s. So that's the target. But here's the really important point that even those that practice bioidentical hormone therapy forget. a blood level on a hormone is not the same as the cell level. Just because you have adequate levels in your blood doesn't mean it appears in the cell. That's the only thing that matters. It's the cell levels that count. But we don't have a way to stick a needle in the cell and find out what's optimal. We don't have that technology yet. And just because you have testosterone or estrogen levels high in your blood doesn't mean that it just appears magically. There's 5 or 6 processes before these hormones get into the mitochondria of the cell where they work. You have receptors, you have cell membrane transporters and receptors in the mitochondrial membrane. So we know that most people, when we optimize them in these ideal ranges, they start to feel good. But if they don't, if their levels are high, but they feel they're still symptomatic, they need more estrogen if you're a woman with hot flashes. If your levels are really high, really low, but you're feeling like, boy, this is too much, we have to treat by the symptoms, not by a serum level. And unfortunately, we want this to be black and white, and it's not. There's so much physiology that goes on here that we don't understand, that we have to treat the person and not a number.
So you're looking at blood levels, but you're also taking symptom histories and experiences of patients and combining them to get the optimal outcome.
And most of the time the blood levels line up, but when we're to their symptoms, but when we're talking about optimization, their symptoms always trump a blood level. If you've got really high estrogen levels and the gynecologist is pulling their hair out because what are you doing to this patient, but they feel great, I leave it where it is. And I say, hey, we don't even need to measure it now. If you feel good, that's the body telling you your cell levels are good.
I think that's really important with thyroid too, which I know we're going to talk about later on also.
Absolutely.
So one follow-up question about lab testing. There's a couple theories for hormone testing. There's blood levels and saliva levels. Do you have any comments on the benefits of one over the other?
Yeah, okay. So Dr. Rouzier, Neil Rouzier is the guru in this field of hormone replacement therapy, in my opinion. I've gone to there's 3 or 4 different major groups that teaches providers how to do hormone therapy. It's about a 50-50 split between serum levels and saliva levels. But most of the research, the good research on reducing cancer rates and heart disease rates, is based on serum levels. But the saliva has the same problem too, because the salivary level doesn't always correlate with the cell level. So because I can tell you if your progesterone level as a woman is greater than 10, your risk based on good studies of breast cancer is reduced by 30%. I don't have that information on salivary studies, but I know on serum studies, the average woman whose progesterone level goes over 30 or over 10 has a reduced risk of breast cancer. So that's why I stick with serum studies.
Interesting. So what determines if a patient should take more or less?
I go by their symptoms. And sometimes that's hard to do. But, when we're measuring blood tests, sometimes patients don't, they don't take their hormones the day they go in. So then they come back low, or they've just taken them and forgotten to tell me, or they've skipped them for 24 hours and they look low. And I'm thinking, oh, we gotta double this. Well, you have to really understand that. And then there's also the diurnal variability. Testosterone levels naturally tend to be higher in the morning just from your own, production. So you just have to really watch and try to understand the timing. But again, it's the symptoms always that trump how we make our final decisions.
So when should hormone levels be tested?
Well, I try to get my patients to test them 6 to 8 hours after they've used them. In women, the trick is they take their progesterone often at night because it helps to induce sleep. But they take their estrogen and their testosterone, maybe their thyroid first thing in the morning. So now you got you got 2 hormones 8 hours apart. And that can be a little tricky. The best, the most compliant patients, they'll wake up at 2 o'clock in the morning and take everything and go back to bed. That's the easiest, but it needs to be consistent. If they're checking at 8 o'clock this month and then 6 months they check it at 3 in the afternoon, you can't compare these numbers because they're not really that meaningful.
Testing. Individuals can test their own.
Yes, well, yeah, you can use outside labs and pay a fee for them, but usually I just have them drawn in our lab, and most of them are sent out. But yes, there are companies that will, you can have your lab sent to, and you can bypass your physician.
And the benefits of estrogen is,
Less heart disease, lowers the risk of dementia. 50% of dementia is vascular dementia. It's a blood vessel problem, but there's also evidence that the neuro changes, the neurological changes in Alzheimer's disease is lessened, is dampened with estrogen therapy, particularly if it's started early. If you're starting estrogen at 75 when you're becoming forgetful, it's too late. It really needs to start sooner. So it can reduce dementia, clearly reduces heart disease, improves the lipid profile, can reverse the vaginal dryness that women have, enhance their libido. One of the most exciting things about estrogen replacement is it helps them lose that visceral fat right around their belly. And women identify with this because when they go into menopause, say 50 years old, and they see me, it's been 2 years since a period, and they've gained 15, 20 pounds around the middle, every one of them will say, I haven't changed anything. I'm eating the same. I'm exercising the same. What's happened? And they get frustrated. They get mad because their doctor says, you got to exercise more. You got to quit eating all the wrong foods. Well, they're not doing anything different. They haven't earned that weight. The reason that happens is estrogen. It declines. When you optimize the estrogen just below that threshold where it's too much, they'll come back in 2 months and they'll say, I've lost 12 pounds right off my belly. That is probably one of the most exciting and reassuring things that can happen to a patient who feels like their life is spiraling out of control. And the same happens with men. When you put them on testosterone, some of the testosterone is converted to estradiol, which is what women need. They'll come back a couple months later and I'll say, how's your weight? Well, it hasn't changed, but I'm bigger and stronger through my chest and shoulders. My shirts are tighter here and my pants are looser. I'm down 1 belt size, but on the scale, I'm no change. It's a redistribution of fat and muscle mass with testosterone, but women can have the same effect. But you can't just see this effect in women with weight loss if they're just getting enough estrogen, just enough to control menopausal symptoms. That's not going to do it. There's quite a gap between this is the threshold for menopause, this is the threshold for too much. I want to get them up to here. I want them just below that threshold where they're feeling bad. And too much estrogen feels like PMS, breast tenderness, bloating, spotting, bleeding, irritability, food cravings, weepy, emotional swings. So we go right below that optimal level of estrogen. And that's when you really see them able to lose that visceral weight.
Okay, so estrogen supplementation for women with breast cancer, testosterone supplementation for men with prostate cancer. What are the rules?
Well, the rules are not too many people are going to believe what I have to say. And there's no way a family physician like me would make these statements without seeing the data and being convinced by the data. And again, this is Dr. Neil Rouzier. I mean, I give him all the credit for this because a conference just last year said, can you give estrogen receptive positive breast cancer survivors, can you give them estrogen? Well, everybody would say, of course not. What are you doing? You're going to kill these women. You're going to go to court and you're going to lose. Well, the answer is 12, 15, 24 studies have shown giving women estradiol, what they need after estrogen receptor positive breast cancer, does not cause recurrent breast cancer. No studies shown that. So what happens is they start feeling better. But here's the problem. And I have a couple women in that category that I've treated, but if I do that to the wrong woman and she's feeling better, but she gets a recurrent breast cancer, then her family doctor and her husband are going to sue me because I've caused it. Well, no, I haven't caused it. Breast cancer can recur, but I'm going to be blamed for it. So, and everybody, and if there was a court, everybody's going to crucify me, say, don't you know better? They're going to throw all this information at me.
Sure.
But what I'm going to do is I'm going to call Dr. Rouzier, and he will come and defend me, and he will win every time in court because this is what he's done. And so, but here was his advice after he explained this to us. So after knowing that it doesn't cause breast cancer, they'll feel good again. They'll feel like women. Would I advise you to do this? The answer was no. And we're like, why? Why can't we do this? He said, because I'll have to come and defend you, and I don't want to put you through that. And I'm kind of tired of being in court doing this for providers. So unless it's your wife or your mother, you don't do it. So that's a tricky one. And the same goes with testosterone and prostate cancer. I have a man who had prostate cancer, felt great on the testosterone, got his life back. Prostate is gone. Now he's got a metastatic prostate cancer in his liver. So they stopped his testosterone. Like, you fool, why did you do that? Now we're going to wipe you out to nothing. And we're seeing the impact of having no testosterone. And so he's stuck. I have another man who, the one that I mentioned, he had prostate cancer. He's doing fine. His PSA is 0. He feels great on it. It's been 2 years now. This other gentleman, that's a tougher situation because I know what they're trying to do. But this is interesting. What he said without testosterone, because he's chemically had his testosterone level driven down to 0. So what's happened to him? He's having bladder problems. He's leaking. He's gaining fat weight around his belly because there's no testosterone, there's no estrogen. And he's depressed. He doesn't have the energy and stamina. That's because of lack of testosterone. But I've given him estrogen. I've got him on 2 milligrams of estradiol, a woman's dose. And guess what's happened? His depression has lifted, his bladder symptoms have improved, and he's losing that belly weight. Now, his strength and his stamina, his libido are still not going to be the same. And we have to make some tough decisions down the road. He might say, you know what? I've got 2 years left to live. My quality of life is not going to be good without testosterone. I want to be back on it. And so that may be a possibility for him. But there's no evidence that shows testosterone causes prostate cancer. It's just intuitively, most providers think, why would you do that? That's crazy.
Interesting.
So what about the benefits of progesterone?
Well, I love progesterone. And here's how I explain progesterone. Every month after a woman's period, she makes a little bit of estrogen. Estrogen level peaks, causes the ovary to ovulate, day 14. Now from day 14 to say day 26, there's that ovary floating, waiting to meet a sperm to become pregnant. So when that pregnancy occurs, now you have uncontrolled cell growth, right? That's a fetus, uncontrolled cell growth. It's very rapid. The immune system goes crazy, like, uh-oh, this is bad. This could be a problem. So the immune system will attack and destroy that tumor, that baby, every time if it's a healthy immune system, except if you have a hormone that's pro-pregnancy, a hormone that's pro-gestation, a hormone called progesterone that stops that process so the baby's not aborted. So it supports gestation. That's why it's there. Women who get pregnant and commonly miscarry, often it's because they don't make enough progesterone. So we give that to them. But here's the cool thing about progesterone. When you're 7 months pregnant and you have a big baby and a big placenta, your progesterone levels are 20 times or more higher than your normal cycling every month. And what does that do in your brain? Brad, I think you'll find this fascinating. The progesterone receptor has the same receptor in the brain as haloperidol, which is an antipsychotic. It interacts at that level. So what that means is progesterone is a natural antidepressant, a natural antipsychotic, and it has mild pain-killing properties. God could not be kinder to women in pregnancy than what he is with that progesterone. And if you ask women, how do you feel emotionally in your second, third trimester? Some of them will say, the best in my life. If I could feel this way emotionally the rest of my life, I would stay 6 months pregnant because I feel so good. So then what happens when a woman has the baby? the baby comes out, the placenta comes out, the progesterone level that's so high comes dropping down to nothing. And now they're in a closet crying with
Postpartum
severe
depression.
postpartum depression.
Hmm.
Do we need to give them Zoloft or do we need to give them progesterone? Well, give them progesterone. And these same mood changes happen to many women who are estrogen dominant because these xenoestrogen exposures, that right before a cycle, they know it's coming because it's breast tenderness, it's bloating. My emotions are swinging from weeping to real irritable. I'm going to bite your head off. I've got menstrual migraine headaches because that excess estrogen causes fluid retention in the brain and causes the headaches. It causes the hands to be puffy, the breast to be swollen and tender, and the food cravings and all of that. So how should we treat that? Well, we tell them, well, when you get that way, just take some Advil. Well, come on. Let's think about the physiology here. The physiology says, I should have this much estrogen every month, but because of all these environmental exposures, I'm really high. My progesterone level is here. When should I take progesterone? Well, instead of Advil, take progesterone. How much should you take? I don't know. When your cramps are bad, you take more Advil. So when your PMS symptoms are bad, you take more progesterone. Some women only need 1 or 2 triturates, some need 8. It depends on how they process it, what their cell does it, how it gets in the cell. So you give them enough to help with this. Now, we could spend another hour talking about the cholesterol pathway and the cortisol pathway because they're all tied together. But women will tell you, when I'm stressed, my PMS is worse. Well, I could show you on that pathway why that happens. Their progesterone is being used to make cortisol because that's a life priority hormone because it's stress, life or death. That's the perception. So their PMS is worse. So some months they'll need more progesterone, but it works so well and it's so simple. And it just makes all the difference.
All right. How about the benefits of testosterone in women?
Testosterone, what I tell women is if you're looking for your libido to be enhanced, the first thing you want to do is optimize your estrogen level because often estrogen makes all the difference for a woman's not only libido, but her response to intercourse. But testosterone will help a woman in a couple of ways. If they're trying to get back in the gym and they just don't have the drive to exercise, testosterone will help that. It'll make them feel competitive. If they're lifting weights, they're not going to get big and massive and ugly, but they're going to get nice and toned. They're going to have good muscle definition. They'll look like they want to look. It will drive them to want to do those things. They'll want to run. They'll want to exercise. They'll want to lift weights. So it'll help them that way. The second way is it definitely can help with libido. But some women, after they're on estrogen, they take testosterone. They'll tell me, hey, I didn't like how I was feeling. My libido was way off the charts and I can't handle that. So I say, then cut it back 2 or 3 times a week, whatever you need to feel good. So it helps with libido, helps with strength and stamina. I kind of let them dose it to find a level where they're comfortable because, libido most of the time has to do with a partner and there's a relationship there and they're kind of used to a certain type of relationship. And if you give a man testosterone and really ramp him up and the woman's not on the same page, now you're creating conflict. So I think for women, they can dose that testosterone according to where they feel best at.
Okay. Do you have anything else? Do you have anything else to add about PMS? We touched on that kind of.
No, it's progesterone.
Okay.
It's not Prozac. It's not Zoloft. It's progesterone.
One of my favorite things is you don't have a Prozac deficiency, right?
Yeah, there you go. That's right.
Okay, Dad, go ahead with your next one.
Okay, how about melatonin? I've heard a lot of customers say they try it, but it didn't work, but others swear by it.
And what I'll tell them is you more than likely you took the wrong melatonin. I don't want my patients to get cheap supplements. And as you guys know, anybody can market a supplement and there's nobody monitoring if it really contains the products that it says on the label or the quality of those products. So what I suggest and what seems to work well for me is a micronized melatonin, a melatonin that's in very small particle sizes that's easily absorbed. I love melatonin for a couple reasons. This goes back to nature or God, whichever way you want to look at it. We make melatonin in our pineal gland, the middle of our brain, this small little pea-sized gland, every day. We go out in the sun, sunlight enters our eyes, and we make melatonin. It gets stored in the pineal gland. When natural sun or natural light starts to decrease, we release melatonin and we feel tired. That's what should happen. But so many people don't make it well. Number one, they're not outside. And if you're outside in Ohio, it's always cloudy and you got your clothes on because it's cold, or you're using sunscreen. So you're not getting natural light to make the melatonin. But then we go to bed at night when we should be releasing it. 200 years ago, we're in a cabin with a candlelight. It's releasing when the sun goes down. But now we've got TV on, we got lights on, we got our iPad or our phone in bed as we lay there with all this artificial light, and we don't release it. So we do a lot of things to disrupt the natural melatonin synthesis and the natural release. It's a powerful antioxidant. It's powerful anti-aging. I've heard people say that it slows down the graying process of hair. But most of all, it's a great sleep aid. I'm pretty sensitive to it. It doesn't take much to knock me out. And if I take too much, I'm kind of drowsy for, half the next day. So I think if it's a quality melatonin, it will work. If it doesn't, then usually what I'm thinking is this is a really uptight person, a person whose brain just does not shut up. Doesn't stop. They're worrying about things. Maybe they're charged on caffeine, but usually it's anxiety. And we get stuck in this loop of worrying about tomorrow or reliving the past, and we can't get off that train, and that keeps us awake. So that's more meditation and cognitive behavior therapy.
So we're at DHEA, and who should take it?
Well, DHEA is a steroid hormone in that pathway of steroid cholesterol synthesis. By the way, we should not be knocking, I'm going to just interject this. We should not be treating cholesterol levels that are high unless there's known heart disease. If you do that, you're going to block the production of testosterone in men and women, because that's what the statins do. They block steroid synthesis. When you do that, you take, just as I mentioned with this gentleman, you take his testosterone level down, he gets visceral fat. It theoretically, in some people, can increase their risk of diabetes, which increases their risk of heart disease. So we should not be using statins as a primary prevention. It's secondary. We know if you have heart disease, that's when you use it, but not just to treat a number. That just makes the doctor and the patient feel better, but there's other consequences because we got biochemistry happening here. But DHEA is in that pathway. And when there's chronic stress, you can use progesterone to make cortisol. You can use testosterone. You can use estrogen to make cortisol. And all those things can be felt. A man's libido will drop. A woman's period will become irregular because of the lack of estrogen. She'll have more PMS symptoms. And so we'll run out on those supplies. But the body says, I've got one hormone here that you're not going to miss too much if we use this to make cortisol, and that's DHEA. So what I see is patients who are chronically ill or chronically stressed, if their level of DHEA is really low, I know they have adrenal fatigue. I know they have cortisol burnout. What I found clinically is replacing DHEA, and a lot of people are not on the optimal end of the scale. It's not highly noticeable. If I was going to prioritize hormones that is going to make a woman feel good, number one, estrogen, number two, progesterone, number three, thyroid, number four, testosterone, and number five, way down on the list is DHEA. It can help with cognition. It can help with libido. It can help with as an antioxidant. It can help you maybe have a little bit more drive, but its effects are very negligible compared to the others. So to me, it's an add-on. Fortunately, it's over the counter, so anybody can get it, but they need to get it from the medicine center. They need to get it from quality suppliers, because a lot of the stuff at the discount chains are not the high quality. So to me, it's an add-on, not as critical as the others we've talked about.
Interesting. So let's take a few minutes and talk about thyroid replacement. How does a patient know if they need thyroid replacement?
Well, so my questions are you losing more hair than normal? Are your nails brittle? Do they break? And is your skin dry? Do you use lotion? If I hear yes to two or three of those, I'm thinking you probably have a thyroid issue. Then on top of that, we can ask questions like, are you tired? Well, a lot of us are tired. That doesn't mean it's a thyroid problem. Are you constipated? That can be a thyroid problem, but so can your diet can cause that. Have you lost the lateral third of your eyebrow? That's a pretty good clinical indicator. Are your periods irregular? Irregular periods are often low thyroid. So, and again, slow cognition, depression. I know back in the 50s, 10% of people admitted to the mental hospitals for depression, severe depression, had severely low thyroid. So you fix that first. So those are the symptoms. If I hear those symptoms and then I measure the right thyroid hormones and I see that they're low, it's an easy one. We give them thyroid. And I really don't care how high the thyroid goes as a blood level, unless I'm getting feedback that it's too much. And too much thyroid will cause palpitations in your chest, and it will cause your heart rate to go up. So I say, figure out what your resting heart rate is now without thyroid. If it goes up more than 20 or 30 points and you're kind of feeling it flutter and patter in there, it's probably too much thyroid. We got to cut it back. But I don't tend to treat that. Again, it's the symptom. What's the cell telling me about thyroid status, not a blood test. The problem, Paul, is that every provider measures the TSH. The TSH is a meaningless test, absolutely meaningless. All that is a signal from your brain to your thyroid gland. Hey, you're not doing your job. I'm going to scream at you and tell you to make more. Or you got a lot of thyroid, just make a few more today. I'm just going to whisper a few more. That's all that tells us. It has nothing to do with what's happening in the cell. So what we really want to know is the hormone level that the cell's looking for. The cell is looking for the free T3. That's what has to be high. You don't measure that unless you've been trained in bioidentical hormones. When you see that's low, and I see that all the time. I work as a hospitalist, and I have elderly people in the hospital. Almost every one of them is hypothyroid. And there's really cool biochemistry with how the thyroid makes T4, converts it, the liver and the cells convert it to T3. Those enzymes become poisoned over time. They have their nutritional deficiencies. There's a lot of reasons why we're low in free T3. And you can try to correct those nutritionally, but the easiest thing is to give them a combination thyroid that's got T3 and T4 in it. Synthroid, levothyroxine rarely work. If that enzyme works, you're good with that. Very small percentage of the population has that experience. Most people say, yeah, I went to the endocrinologist. I still feel terrible. He raised my dose, or he said my TSH was fine. He wasn't going to raise it. Well, okay, look at the T3 level. Listen to what the patient's telling you. What the endocrinologist and many others will say is, oh, we can't give you too much thyroid because that'll cause atrial fibrillation. It doesn't cause atrial fibrillation. Again, I'm not saying this because I'm the expert. I've just been taught by the expert who shared the science with me. Atrial fibrillation is associated with a condition called Graves' disease, which is hyperthyroid. Association does not mean it's a cause. So what we know with Graves' disease, it's an autoimmune condition. The body is attacking the thyroid for some reason. And for some reason in that state, you can have atrial fibrillation, which can cause a stroke. That's a bad situation. That's life-threatening. So you can't say that thyroid causes atrial fibrillation because it doesn't. Thyroid causes tachycardia, which is a rapid heart rate. No evidence it causes atrial fibrillation. It's associated with high thyroid levels associated with Graves' disease and atrial fibrillation. But that's as far as you can draw that conclusion. And that's where that fear comes from. And it's an association, not a cause effect. No double-blind placebo-controlled study has ever proven that giving someone high thyroid levels causes atrial fibrillation.
I think we got these last two questions about thyroid in the previous discussion. Is that correct, Brad, or what do you think?
Yeah, we covered synthroid and AFib and normal ranges. I mean, basically, doctor, your takeaway, and I agree with you wholeheartedly that you have to take into consideration as much from the patient and their symptom profile And you use the labs too, but you gotta mesh them together, because you can't
Right.
treat the whole patient just looking at the screen on the lab
Right.
numbers.
Yeah.
So
Yeah, exactly. Yeah, we want to do that. And then the last thing I wanted to say about testosterone is I have men come in the office with erection problems and they think testosterone is the cure.
Hmm.
If they're an obese man, testosterone is not the correction. The reason they have erectile dysfunction problems is usually not a lack of estrogen, it's a lack of nitric oxide. That's a cool topic we should do another time,
Okay.
because nitric oxide is what keeps the blood vessels dilated. It
Hmm.
keeps the blood pressure down. It's why people have hypertension most of the time. It's why women have sexual dysfunction, because they don't have enough nitric oxide to dilate their clitoris. So men are often disappointed. Their libido will be stirred with testosterone. If they're sort of borderline, that might be just enough to fix their mild ED issues. But that's not how we correct erection problems. It's with nitric oxide supplementation and nitric oxide nutrition to help us make it more effectively. So I just wanted to throw that out there because, like I said, a lot of men will come in and I can almost look at these guys and say, we'll try this, but I'm not confident this is going to help your erection problems.
So you got 10,000 products out there on the internet that say they're going to raise your your nitrate level.
Yeah.
What's the deal?
Well, this you guys have probably come across this. These products are based on biochemistry. They'll look at the biochemistry for nitric oxide synthesis, and many of them will say, oh, you need L-arginine to make nitric oxide.
Yeah.
You
Okay.
do. You do need that, but that's not the problem. We don't have an L-arginine deficiency. We have a deficiency of the nitric oxide synthase enzyme because we've poisoned it with our lifestyle. We've poisoned it with nutritional deficiencies, with visceral fat. We've done all these other things. So giving this supplement or giving this mineral to help that nitric oxide synthase is probably not going to fix the problem. So there is a supplement we can talk about another time that I had great success with, but also understanding how do you help the body make its own nitric oxide naturally is a really simple but very cool approach.
Interesting.
all right, Dr. McKnight, time for the final word. Would you like to share your contact information with our listening audience and any messages that you'd like to have for final takeaways?
Okay. Yes, my office number is 740-922-0000. If your listeners are interested in hormone replacement therapy, have them make that as a notation that they were on this call or they heard this conversation, because otherwise I'm pretty full and I'm usually pretty selective. But I'm down in Denison, Ohio, which is about 10 miles southeast of New Philadelphia. And I use the medicine center often. Brad, I think it's great that you understand hormones. And I tell my patients, if you have questions, Brad can help you. We see things very similarly. And it's nice to know there's somebody locally that does this, that's accredited and does it right. And we work well together. So I'll just put that plug in for you.
Thank you very much.
I guess my take home message is, first of all, that we have to have optimal hormone levels for optimal health. And we have to have optimal nutritional levels too, but optimal hormone levels. The second take home message is that we have hormonal imbalances because we have endocrine disruptors, primarily things that block testosterone receptors and interfere with estrogen biochemistry. And we're all exposed to that. And some people, maybe with a genetic predisposition, feel the effects more strongly. The next point is that blood and salivary levels should not dictate how we treat a person. It's their symptoms. And the final point, which is the message I'm most passionate about with the wellness program that I have, we've had over 3,000 people graduate from it. Everyone has referred family and friends to it. Everyone's been completely satisfied with it. And the message is that if you can empower yourself with information to help your body heal at any age, and you can safely optimize these hormones, you can optimize nutrition and supplements and healthy thoughts. You do all these things, and you'll be surprised where you end up. My dad almost died of a bladder infection about 2 months ago. He's going to be 95 in July. We transferred him to our hospital, and I got to admit him. He was here for therapy. He came from Columbus. I said, bring him here. Let's work on therapy here. Let me try to fix him. His testosterone level was the lowest I've seen in anybody. I said, Dad, you were on cream. Now you get a shot every week. I put him on supplements. I put him on a nitric oxide supplement. 6 weeks later, his cognitive function is better than it was 5 years ago. His ability to get up and move. He is a completely different person with just some simple approaches. His quality of life is back. The quality of life he had, back in March, I was ready to say goodbye to him. I thought, this is awful. I don't want him to live like this. But with hormones and nutrition therapy, he's back, and I think his quality is good, and he's happy with it. So good information, balancing hormones and nutrition can make all the difference. You never know where you'll end up when you get that addressed. But thank you guys for letting me be on this program with you. I really appreciate it.
Great.
Thank
Thanks, Dr. Timothy McKnight, family physician with Trinity Health System, Twin City Medical Center. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to Studio Arts and Glass. And of course, our technical producer, JD DeAngelis. As always, we thank you, listeners, for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you right here again next Friday on News Talk 1480 WHBC.